Welcome to another episode from the Veterinary Research Channel. Today, we're diving into a recent study that looks at how different surgical techniques for correcting excessive tibial plateau angle in dogs affect the bone's shape.
That's right. We often talk about common surgical procedures like the tibial plateau leveling osteotomy, or TPLO, for addressing cranial cruciate ligament rupture in dogs. But sometimes, dogs present with what's called an excessive tibial plateau angle, or ETPA, which is greater than 34 degrees. The standard TPLO can have drawbacks in these cases, like potential tibial tuberosity fracture, or not fully correcting the angle.
So, veterinary surgeons have developed alternative techniques to handle this excessive angle. This study, titled Morphologic Impact of 4 Surgical Techniques to Correct Excessive Tibial Plateau Angle in Dogs, a theoretical radiographic analysis, takes a closer look at some of these alternatives. The goal was to see how these different procedures impact the shape of the tibia, specifically looking at the tibial plateau angle itself, the length of the tibia, and the mechanical axis shift.
And they compared 4 specific techniques: a combination of center of rotation of angulation-based leveling osteotomy and coplanar cranial closing wedge ostectomy, which we'll call Group A, a combination of tibial plateau leveling osteotomy and cranial closing wedge ostectomy, Group B, the modified cranial closing wedge ostectomy, Group C, and the proximal tibial neutral wedge osteotomy, Group D. The researchers hypothesized that there wouldn't be any differences in these morphologic measurements after correction using the different techniques.
This study was a retrospective radiographic analysis, using virtual corrections on X-rays from 16 dogs with excessive tibial plateau angle. They measured things like the tibial plateau angle, tibial length, and mechanical cranial distal tibial angle before and after performing these virtual corrections. The mechanical cranial distal tibial angle is an indicator of mechanical axis shift.
Let's get into their findings, starting with the tibial plateau angle itself. Before any correction, the average tibial plateau angle in these dogs was about 42.7 degrees. After the virtual corrections, the average post-correction tibial plateau angles were different for each group. Group A was about 10.5 degrees, Group B was about 6.8 degrees, Group C was about 4.8 degrees, and Group D was about 7.1 degrees.
It's interesting to note that there was no significant difference in the post-correction tibial plateau angle between Group B, the combination TPLO and cranial closing wedge, and Group D, the proximal tibial neutral wedge osteotomy. However, there were differences between all the other combinations of groups.
They also looked at the accuracy of the correction compared to the target angle for each technique. Group A and Group D showed the least variation from their specific target angles. Group A, the combination CORA-based leveling osteotomy and coplanar cranial closing wedge, actually slightly overcorrected the angle, while Groups B, C, and D resulted in some degree of undercorrection. The accuracy differed between Group A and Group D.
Now, let's talk about changes in tibia length. This is a really important factor to consider. They found that Group B, the combination TPLO and cranial closing wedge, resulted in shortening of the tibia compared to the other techniques. Groups A, C, and D showed only small positive changes or even slight lengthening. This difference in tibial length change was statistically significant between Group B and each of the other groups.
And finally, the mechanical axis shift. All 4 techniques caused a cranial shift of the mechanical axis after the virtual correction. However, the magnitude of this shift varied significantly between the groups. Group A, the combination CORA-based leveling osteotomy and coplanar cranial closing wedge, showed the largest deviation, indicating the greatest mechanical axis shift. Group B, the combination TPLO and cranial closing wedge, demonstrated the least mechanical axis shift.
So, their initial hypothesis that there would be no differences in post-correction morphology was rejected based on these results. Even though all techniques were able to achieve a tibial plateau angle less than or equal to 14 degrees, which is considered clinically acceptable in some studies, they each impacted the tibia's shape in unique ways.
The discussion highlights that while a target tibial plateau angle below 14 degrees seems acceptable, the ideal angle is still debated. The study used the specific target angles described for each technique by the original authors when calculating correction accuracy. For example, the combination CORA-based leveling osteotomy and coplanar cranial closing wedge targeted 11 degrees, the combination TPLO and cranial closing wedge targeted 5 degrees, the modified cranial closing wedge osteotomy targeted 0 degrees, and the proximal tibial neutral wedge osteotomy targeted 6.5 degrees.
Comparing their virtual results to previously reported clinical outcomes, the post-correction angles for the combination CORA-based leveling osteotomy and coplanar cranial closing wedge and the combination TPLO and cranial closing wedge were similar to clinical reports. However, there was a larger difference between their virtual modified cranial closing wedge osteotomy result and the reported clinical outcome for that technique.
It's known from other research that cranial closing wedge ostectomy techniques can sometimes undercorrect the tibial plateau angle, particularly in cases with excessive angles. Modifications to the cranial closing wedge, such as the neutral wedge ostectomy used in the modified cranial closing wedge and proximal tibial neutral wedge osteotomy techniques, have been associated with less tibial shortening, less mechanical axis shift, and improved accuracy compared to standard cranial closing wedge techniques.
The potential for tibial shortening is a key consideration, especially because it could stress the fibula if not managed, potentially leading to a fracture after surgery. While some studies suggest a small amount of shortening might not be clinically significant, comparing these studies can be tricky due to different measurement methods.
The mechanical axis represents the weight-bearing axis of the tibia. A shift in this axis could potentially alter how load is distributed across the nearby joints, which might be undesirable, though the clinical impact of this shift in dogs with excessive tibial plateau angle isn't entirely clear. As mentioned, the combination CORA-based leveling osteotomy and coplanar cranial closing wedge caused the most significant mechanical axis shift in this study.
The proximal tibial neutral wedge osteotomy is described as being similar to the modified cranial closing wedge osteotomy in that they both use a neutral wedge. However, the proximal tibial neutral wedge osteotomy bases its angular correction on the magnitude of a proximal tibial center of rotation of angulation, unlike the modified cranial closing wedge osteotomy, which uses the preoperative tibial plateau angle. The proximal tibial neutral wedge osteotomy technique involves calculating a proximal tibial mechanical axis and its intersection with a distal axis. This reliance on the center of rotation of angulation might be advantageous if there are other deformities in the proximal tibia besides just the excessive slope.
The authors also touch upon common complications seen after surgical correction in these cases, which include loss of tibial plateau leveling, tibial tuberosity fracture, and issues with implants. All the procedures analyzed here use additional fixation methods beyond just a bone plate. Surgeons typically try to avoid making cuts too far down the tibia, below where the patellar ligament attaches, to reduce the risk of tibial tuberosity fracture, and these techniques specifically aim to prevent that.
It's important to remember some limitations of the study. It was a virtual radiographic analysis, so the results might not perfectly reflect what happens during an actual surgery. They also followed the standard descriptions of the techniques and couldn't account for individual variations surgeons might make or the effects of the saw cuts during surgery. Plus, the relatively small number of tibias included could potentially affect the statistical outcomes.
In conclusion, this study shows that while all four techniques effectively corrected the excessive tibial plateau angle to a clinically acceptable range in this virtual setting, they had distinct impacts on the tibia's morphology. Surgeons need to consider these potential changes in mechanical axis shift, tibial length, and correction accuracy when choosing a procedure for a patient with excessive tibial plateau angle.
Exactly. However, we still don't know exactly how these morphologic differences might affect the dog's function and outcome after surgery. Further clinical studies, perhaps using objective methods like gait analysis, would be beneficial to help determine if one technique truly offers a significant advantage over the others for managing excessive tibial plateau angle.
Thank you for listening to the Veterinary Research Channel. A link for the referenced paper is in the video description. Remember to test your knowledge by answering the questions in the description, and as always, keep those minds inspired, hearts light, and tails wagging.